Good morning, everybody. Morning. Good. Thanks so much for joining us this morning. So this is session 8, which is the mini review on pregnancy and maternal health is the title, but we do have a variety of wonderful presentations coming to us this morning. My name is Sue Peterson. I'm an endocrinologist here, well, not quite here, almost here in Calgary, next door. And I will be chairing this session along with my colleague, Dr. Martin Binks from Texas Tech University. We have 4 presentations. The schedule does not allow a time for a panel discussion afterwards, so if the speakers end with a couple of minutes to spare within their segment, which are 15 to 20 minutes, then we'll open for questions if we have time. Otherwise, our speakers have very kindly agreed to stick around afterwards if you have any questions, and we'd invite you up to come and chat with them afterwards. So our first speaker is Mr. Brendan Goodman. So Mr. Brendan Goodman is going to speak about the weight of living personal perspectives. Brendan attends university, and he's looking forward to a career in politics or law. He has faced the challenges and difficulties of having overweight his entire life. He attended many unsuccessful weight loss programs until he found the Sick Kids Team Obesity Management Program. Please join me in welcoming Mr. Brendan Goodman.
Good morning, everyone. I hope all of you had a nice, restful sleep last night. As stated before, my name is Brendan Goodman. I am studying political science at York University in Toronto. I am a patient advocate and sit on the Public Engagement Committee for the Canadian Obesity Network, and this is my story, living with obesity. I've always been overweight, as long as I can remember, even since kindergarten. It's always been an attribute of my life in some way or another. When it comes to school, I was always behind other kids in school. I was always the odd one out in the group, and this led to ostracization in school as well as a crippling social anxiety. Gym class was always a source of humiliation, as I struggled to keep up in gym and would always be the last one to be picked for any kind of sport. This in turn had caused me to lash out for attention and a place on the social totem pole in school. My behavioral issues had gotten so bad to a point that I was sent away to a school for troubled children in the 7th grade for 2 weeks, until luckily my parents had pulled me out of it. Now, speaking of my parents themselves had always tried their hardest to make sure I would have a fair shot in life and would always go to bat for me. When school would try to pull down my self-esteem, my parents and siblings were always there to bring it back up. Eating habits, however, though, were an area that my parents weren't the best at, as they themselves had never had a healthy relationship with food. However, food has always been a challenge for the entire Goodman family: parents, aunts, uncles, cousins, sisters, brothers. Food has always been a coping mechanism and has always been present in our family in some way or another. It has always been a focal point at family gatherings, and it was something each Goodman has dealt with in different ways. Now, I want to move on a bit to the medical side of my story. And during all this, when I would go to doctors, they would always make appointments about weight and just tell me to eat less. They would make no attempt at other methods, and this led to doctors' visits becoming something of a thoroughly negative experience. After each visit of my doctor lecturing my parents about obesity, I would be put on a crash diet by my father for a week and then go back to normal. This was coming from a father who was seeing his own children going on the same path of obesity that he had been on at the same age, and struggling to find tangible ways to help his children. Each time, though, all those diets would sow more distrust of the medical system and not want to go back to any sort of weight loss program. Eventually, what happened was I stopped going to doctors or any kind of professionals from the ages of 10 to 15. Although the reason partly is because what the doctors would do is they would go from 0 to 100. And so they might say, Okay, you eat a large pizza and 2 liters of soda for dinner. They then pull a sheet off of a pile that they have printed of a preset plan and say, okay, eat 1 slice of pizza and a salad. And they thought that was, incremental. And sometimes they would even result to threats and demands to try and make their changes. One story that always sticks in my mind is I was going to intake in a program in a hospital in Toronto. And I was meeting with 2 people. I was meeting with a nurse who was taking my measurements and getting me done, and then the doctor for the program. The nurse was great. She was very helpful, very nice, very supportive. We can do this. We can get through this. We can just work at not, gaining any weight right now. But then the doctor came in, and he was all fire and brimstone. This is horrible. You're 9 years old. Your blood pressure's high. Your weight's high. This is too high for what it is. And he said, at this rate, you'll be dead in 20 years. And you can imagine at 9 years old how traumatizing it would be being told you'll be dead in 20 years. And so the reason I think that this happens is not necessarily due to a lack of knowledge being imparted towards these doctors in research-proven treatments for obesity that we have seen being presented at this conference. It's not necessarily due to malice. Children are seen as having no agency for themselves, and thus being told what to do and using fear sometimes is an assumption some authority figures can make. And where finally, at age 15, I joined the Kids Childhood Obesity Program known as STOMP, and I worked with them from 4 years, from age 15 to 19. At first, when I joined, I was very skeptical that they were just going to be one of those other programs that ultimately did nothing for me, and that would try to bludgeon weight loss. They had a full complement of doctors, however, to support you, from dietitians, psychologists, fitness trainers, and as well as a full team of medical staff. However, the reason that that STOMP had worked for me is that they had a multifaceted approach to weight loss. And what they would do is they would ask me the changes I could make, not tell me. They would give me help and would only make suggestions to change eating patterns only when I may not be fully committed to the change. They were the guardrails on the road, not driving the car. At 17, through STOMP, I had a sleeve gastrectomy, which cut out 75% of my stomach, leaving it to the shape of a banana. And now at 22, I've lost over 100 pounds. This enabled me to walk more and to do more exercise and see the world in a healthier light and start to keep up with my peers when I could not keep up with in decades past. However, I always stress that surgery is a tool. I did not get a lobotomy, and so surgery only helps the process of weight loss so long as the person is willing. Especially now, being almost 5 years out, I have to be mindful to maintain the lifestyle I have. Even today, though, obesity is a challenge that still affects me. I always try to make a good second impression with people because I know the way that I look will make the first. An example I always think of in terms of that is even today at university, I'll be in classes where professors are terrible with names, don't remember anyone, don't know anyone, but yet for some reason magically they will still always remember my name, guessing my personality. However, living with obesity, though, isn't all doom and gloom as it can be portrayed as. Even before losing the weight, I was happy and thankful to have a strong and loving, supporting family. Without them, I wouldn't be standing at this podium today. Now, being that we are having talks and discussions on pregnancy, I would love to regale you with my own personal story of pregnancy. But as we haven't figured that part of anatomy out quite, I will like to give some personal stories of how obesity, though, has affected my family in terms of pregnancy and children and all that. And there is a genetic history in my family of heart conditions, diabetes, and obesity, with at least half of my family being large in different respects. Even 80-year-old pictures of my grandparents showed them being larger for that time. When it comes to my mother, she is what one might consider skinny most of her life until she had my older sister, Sherelle. When she had her, she never quite got that baby fat off, and by the time she had her third child me 6 years later, she was, again, never got the fat off, and she was pretty much obese and has been obese since then. On top of this, despite not having problems though conceiving all three Goodman children, we all had to be born by cesarean section. This was due to a narrow birth canal that was inherent in my mom's family. And it is interesting to note, though, that of the three Goodman children, I was the smallest, at only 5 pounds. Concurrently, though, my mom's sister, who was overweight her whole life and has had tremendous difficulty conceiving my cousin, was told it was a miracle that she even became pregnant with her. As a result of this, my aunt and uncle only had one child, with all three members of the family developing diabetes at some point in their life. On my dad's side as well, one of his two sisters lost her first baby during pregnancy and was just barely able to have my other cousin. Conversely, one of my second cousins, who is Orthodox Jewish, which implores its followers to have as many kids as possible, had over 9 children, and those children have had 3 or 4 children, and appear to be being quite fertile. Overall, though, genetically, my family has fallen in line with the research that you will be seeing presented later here today. So I want to thank you all for listening to my presentation, and I hope this has given you some insight on what it is like living with obesity. Based on what I've observed here at the summit these past couple days, it seems that the research is on the right track in terms of the realities of obesity and finding effective treatments for obesity. All most of us ever ask is to be treated with the same respect and dignity afforded to all Canadians. Thank you. Yeah, no problem.
So we have a few minutes for questions, if anybody has anything they'd like to ask. It's very early in the morning for that, right? Okay, well, thank you very,
No
very
problem.
much.
Thank you so much.
Thank you. It's my pleasure to introduce our next speaker, and the title of the talk is Prenatal Stress and Obesity, Results from the Stress in Pregnancy International Research Alliance Spiral Trial. Kelsey Needham Dankos? Dankos. Thank you.
Hi. Let's see if I can find the right window here. Wonderful. So good morning. My name is Kelsey Dankos, and I'll present on results from the spiral studies. I'm at the University of Quebec in Montreal. Before I begin, I want to point out that I have no commercial support and no conflicts of interest to declare, and you can see our funding sources there, so mostly CIHR, but also the US NIH and FRSQ and the Natural Hazards Center. The studies I'm going to be presenting are very large, multidisciplinary, so I just want to show some of the team members right away because it really is a fantastic group. So these studies are led by Suzanne King at McGill University in Montreal, and there's collaborators in the United States and in Australia. Today I'll present an overview of prenatal stress and child development. I'll talk about human studies of stress during pregnancy. I'll present some background on prenatal stress and obesity with results from the spiral studies, and I'll talk about some of the broader implications of this research. So if you were at the sessions yesterday on pregnancy, you've already had a nice overview of the developmental origins of health and disease, or DOHAD. But in general, the idea is that the environment during gestation affects health not only at birth, but throughout life. So for example, if a mother has poor nutrition during pregnancy, we might expect that her baby would be born small at birth. But what we've seen from studies in DOHAD that was really remarkable is that the health effects persist throughout life. Studies some 30 years ago by David Barker and colleagues showed that babies that were born small had later risk for obesity and diabetes in adulthood, and that's what really started this research on the developmental origins of health and disease. So whereas these early studies focused on nutrition, today we've seen DOHAD studies on physical activity during pregnancy, tobacco use, environmental toxins, stress, and a variety of environmental exposures. I'm clearly interested in stress. And the basic idea of stress in DOHAD is that stress hormones can cross the placenta, and at high levels they can affect fetal development. Now, the effects really vary. First, you can imagine that the effects we see vary depending on the severity of the stress. We would imagine more negative effects with more severe stress exposure, more stress hormones, more effects on the fetus. We also often see sex-specific effects, with boys in general showing greater susceptibility on most of the things we've measured, at least. And finally, timing of exposure is a really important component. Fetal development is not linear or uniform across gestation. There's different systems that are sensitive at different periods of time. So you can imagine that the effects we see in children exposed to stress during pregnancy or during gestation would depend on the timing at which they were exposed. We have some excellent studies that start to highlight the mechanisms linking prenatal stress to later obesity and metabolism. A general pattern that we see is small size at birth, followed by later obesity and diabetes. It's the same pattern that was shown 30 years ago in those early studies on nutrition. So we see the same thing with stress exposure. First, babies that are born small could have reduced organ size and capacity, and that could affect their metabolic health later in life. Second, animal studies show us that there are effects on appetite regulation. So it would seem that stress can affect the developing HPA axis, and that could affect lifelong appetite regulation. In animals that have been exposed to prenatal stress, we see greater dietary intake when they're adults, and we see effects on their food preferences such that they prefer foods that are fatty and high in sugars compared to their non-stressed counterparts. And finally, we see some effects on metabolism at the cellular level. So again, in animals exposed to stress during pregnancy, we see delayed glucose clearance. And if we look at their beta cells, they show hypersecretion of insulin, and they're less sensitive to glucose compared to non-stressed animals. So we have multiple layers of mechanisms. These are in animal studies. Human studies are a little more difficult. We can't just randomly assign pregnant women to stress or non-stress groups. I can think of thousands of ways to stress out pregnant women, but, ethics. So we just have to come up with something else. There are wonderful studies that have tried to get around some of these challenges. So some people have used retrospective studies of stress during pregnancy. They might look at a group of kids with diabetes and a group of kids without, and ask their mothers, what stressors did you experience during pregnancy? These have been incredibly important studies, but they can be biased. My impressions of my stress during pregnancy could be influenced by my child's health. Right, so we have a bias in retrospective studies. Other people have used stressful life events. So women who have experienced job loss or divorce or death of a relative during pregnancy, and then we would follow their children. Those are great studies too, but one of the big problems is that we can't identify the timing of the stressor often. So imagine for the death of a relative or for divorce, usually there are many other stressful events leading up to that variable that we're measuring, and it's very hard to identify some time frame of stress exposure. And other people have used different psychosocial health measures that are related to stress, but not necessarily stress. So we can analyze anxiety and depression during pregnancy. Certainly these are related to stress, but they're not independent of maternal characteristics. So we can't just draw a straight line between the stressor and child development, because there are genetic factors, social factors, major illnesses, for example, that could affect a woman's risk for anxiety, and that also have their own effects on child development. So it's really hard to pull out which aspect is acting on development. So what do we do? Well, natural disasters serve a purpose in this case. They provide natural experimental models of stress. They're useful models because they affect a large number of people. These hit whole regions, and they affect everybody at the same time. We know when a cyclone hits. We know when an ice storm hits. We can identify the day, and it affects everybody on the same day. And in general, the stressor is independent of maternal genetic and socioeconomic characteristics that are some of those confounders in other studies. So again, since a natural disaster hits a whole region, it's really not targeting any one particular type of person. In 1998, the province of Quebec experienced a severe ice storm. It was labeled the most costly natural disaster in Canadian history. 3 million people were without electricity for up to 6 weeks during the coldest period of the year. So I wasn't there. I was still in the United States at the time, hanging out in Kansas studying. But there was somebody who was there. Suzanne King was at the Douglas Hospital Research Center. She had experience on stress during pregnancy, and she realized the potential to create a study following the ice storm. In fact, she realized that this would be a good opportunity because she checked her own blood pressure. She was, taking care of her own 2 kids. Her mother-in-law was sick. She checked her blood pressure and realized it was through the roof and said, oh my gosh, pregnant women, I have to create a study. Anyway, so Suzanne King recruited, I think, 180 women who were pregnant during the ice storm or who conceived within the following 3 months when stress hormones could still be elevated. And she assessed stress due to the storm. Now, I want to take 30 seconds to talk about measuring stress, because stress isn't just one thing. It's complex, and we always have to have multiple measures of stress. We try at least, to have some objective measure of the stressor. When we talk about stress, there's this external thing that's putting a pressure on us, right? In this case, it's the ice storm. So we ask, what happened? How many days were you without electricity? How many days did you spend in emergency shelters? How many family members were injured? What happened? In stress studies, there's also an inherently subjective component, because each woman might look at that objective stressor and handle it differently. So the level of stress depends on my perceptions of my capabilities to deal with this stressor. So we need measures of women's perceptions of the event. And finally, stress induces biological and physiological changes, heart rate changes, changes in stress hormones that can be measured. So in the case of the ice storm, we have objective measures of the stressor and subjective measures of the women's response, and we have cortisol. But the best measures are the first 2, and that's what I'll talk about today. Since 1998, this team has conducted regular assessments of children's outcomes. So we have cognitive, behavioral, motor, and physical and metabolic outcomes. Like I said, these are very multidisciplinary studies. I touch only one part of these data. I joined the team in 2010 to look at physical and metabolic measures. So we have anthropometric measurements, we have percent body fat through air displacement methods, and we have oral glucose tolerance tests. So I analyzed relationships between stress due to the ice storm and children's measurements at birth. It's a good starting point. And the first thing I noticed is that the babies were slightly shorter than I might have expected. Their birth length Z-scores were a bit smaller compared to their Canadian counterparts. Not much, but a bit. Okay. Then I saw that the subjective stress due to the ice storm affected children's birth weights, or was associated with children's birth weights. So on the top, we're seeing children exposed in early, mid, and late gestation to the ice storm, and you can see a dip in the middle, right? Kids exposed during the 2nd trimester have smaller birth weight. That's consistent with animal research. And we see the strongest effects among children whose mothers had high subjective responses to the ice storm, so that's the solid red line on the bottom. We're explaining about 4% of the variability in children's birth weights. It's a modest effect, but it's consistent with the animal literature and consistent with other human studies. We also see effects on head circumference. So again, if we look at that solid red line, that's high levels of subjective stress, and we see that in this case, it's early gestation where the children are sensitive. So children exposed to high levels of subjective stress in early gestation show smaller head circumference compared to other children. And there we're explaining about 6% of the variability. In childhood, there were measures of height and weight collected, so we could analyze relationships between stress and body mass index. And in all of the statistical models, we control for maternal body mass index, we control for socioeconomic status, big important confounders. We include them as much as we can. And still we see that greater stress predicts body mass index, and it predicts risk of obesity. So here in the figure, I've simplified it, but we're just looking at kids with low prenatal stress exposure in yellow and high in red. And you can see that at ages 5.5, 8.5, and 11.5, the prevalence of obesity is higher among kids with that high prenatal stress exposure. In fact, I don't know why I didn't put it here, but the effects are even stronger for central obesity specifically. And like I said, these effects persist in more detailed statistical models. When we look at stress and body mass index specifically, the effects persist throughout childhood. So here we're looking at ages 5.5, 8.5, up to 15.5. and we have body mass index there. And in the solid black line, we have children with high prenatal stress exposure. The dotted line is low. So you can see that at all ages, the children with high prenatal stress exposure have a higher BMI. What's really surprising to me, at least, is that the strength of this relationship increases with age. The correlation between prenatal stress and body mass index increases from age 5.5 to age 15.5, such that the gap between those three groups of kids gets bigger with age. I would never have predicted this. If you had asked me years ago, I would have said, well, of course, the postnatal environment is going to eventually erase or at least mask the effects of prenatal stress. And it does for some outcomes. But when it comes to body mass index and obesity, the effects seem to keep getting stronger with age. Now we're measuring the ice storm kids. They're not kids anymore. They're 18, 19 years old, and we're still seeing growing effects. In adolescence, the kids came into the lab for oral glucose tolerance tests, and we saw that greater stress predicted insulin secretion. So here on the bottom, you're seeing objective stress exposure, and on the y-axis, we have insulin secretion. You can see that positive relationship. And again, this is independent of all of the confounders that we could include in the model. We can't control for everything, but we try. We're controlling for the kids' own body mass index or their percent body fat. We're controlling for their number of relatives with diabetes. And again, these effects are modest, but they're consistent. In fact, that we see any effects at all is to me amazing, because I understand that the ice storm was stressful, but women didn't lose their homes. Their lives were still intact. Their families were still there. So it was a stressful event, but if we see effects among women in Quebec, imagine in other countries, imagine in low and middle income countries, imagine during warfare, imagine other stressors that could have even more severe effects. And so the fact that we see modest effects is remarkable to me. It would be really lovely to replicate these studies among other groups of kids and with other disasters, and in fact, that's just what the Project Ice Storm team did. So in 2008 in Iowa, United States, there was extreme flooding, the worst they had seen in a century, I think. And 3 years later, there was extreme flooding in Queensland, Australia. And Suzanne King had collaborators in both sites, and so that provided a great opportunity to create 2 other studies of stress due to natural disasters. And thus was born the Stress in Pregnancy International Research Alliance. So this is really nice because we can learn from Project Ice Storm and add in things that weren't done in 1998, right? We could add in more detailed measures of physical growth, for example, and we could assess children at earlier ages. So some of the lessons that we're learning from these other studies, in the Queensland flood study, for example, instead of just analyzing height and weight, we've looked at skin fold measures of adiposity, and we can see effects as early as 16 months of age. We can also see in this group that interventions can diminish the relationships between prenatal stress and later adiposity. So here, on the solid line, you're seeing the standard obstetric care group, but on the dotted line, you're seeing women who are in a group midwifery practice that provides more social support, and that seems to diminish a bit the relationships between stress and children's skin fold ratios. We're also starting to see some of the mechanisms associated with stress and later obesity. So here we're looking at epigenetic profiles of children exposed to the ice storm. In green, we have low methylation, in red, we have high, and each column is a child. And the thing I want to point out is that we really see clusters. The methylation profiles group between kids who have low prenatal stress exposure there in blue and high prenatal stress exposure there in red. So I'm not an epigeneticist, but my friends who do epigenetics tell me that this is a pretty impressive clustering of methylation profiles. What do these studies show? Well, prenatal stress is associated with growth and metabolic outcomes. It's not just confounding. The effects are modest, but they're consistent and they're persistent. Epigenetic changes are part of the pathway, and we can intervene. What do they not show? Well, there's a ton of other metabolic outcomes that we could analyze. It would be lovely to have lipid panels or more detailed measures of body composition or resting metabolic rate. Maybe then we would see more extreme effects. It would be nice to see other mechanistic pathways. So we talk about epigenetics, we talk about stress hormones, but we also know that stress is associated with behavioral change. It could be that women are changing their diets in response to stress, and this is one of the mechanisms on the pathway between prenatal stress and later obesity. And we also don't know much about the postnatal environment, such as infant feeding patterns among small babies that could affect their catch-up growth and later obesity risk. That might be one of the areas to intervene postnatally. And finally, we don't know about effects in underrepresented communities. These samples are biased. We have highly educated women with high levels of social support. What about low and middle income countries? What about socially disadvantaged women? Maybe the effects are different. We don't know. But we have groups that are working on these things. So Suzanne King and the Spiral team are working on designing the next round of assessments among the Queensland flood study kids at the ages of 7 to 9. They'll add more detailed growth and metabolic measures. And I'm not too shy to ask for advice. If you have measures to recommend, we will work our best to include them. I'm working with Sonia Gagnon at Hôpital du Sacré-Cœur de Montréal to start to look at other mechanistic pathways. So we're looking at chronic stress and maternal health behaviors to really start to tease apart their interactive effects. And finally, since 2007, I've worked in Vanuatu, which is a lower middle income country in the South Pacific. And with my colleague Giovanna Buffa, we're working on replicating these chronic stress and health behavior studies in Vanuatu. So I think for the broader implications, certainly these studies are further highlighting the complexity of obesity. We're looking at individual factors, intergenerational, and broader social and environmental factors that are all playing a role here. From a political perspective, these studies could support the importance of programs to improve the environment for pregnant women. If we can help to reduce women's stress levels during pregnancy, maybe we can affect the health of the next generation. And from the public health perspective, this could really inform interventions, I think. So for example, we've seen in intervention studies that stress and physical activity and diet, they're all completely linked together. You know, physical activity can reduce stress. Stress reduction interventions can improve diet. They're all tied together. And usually combined interventions show even greater effects. So maybe this points to the importance of including stress in some of our behavioral interventions. And maybe the way we measure success in interventions could be expanded. You know, it's frustrating when we have a dietary intervention and then we don't see changes in diet. But if it's helped to reduce stress levels, maybe it still has important effects. And we see that interventions for pregnant women often improve the health of the entire family. So I think the idea of helping to reduce women's stress levels during pregnancy could have much broader implications on the health, not only of the pregnant woman, of course, but her baby and the entire family. So again, the Spiral team, thank you so much. Time for questions?
Thanks so much, Kelsey. That was very, very fascinating. I'd like to invite our third speaker, and this is Rhonda Bell, and the title of her presentation is Enrich, Supporting Healthy Weights in Pregnancy and Postpartum. Dr. Bell is a leader of a team of trainees, graduate and undergraduate students and postdocs, and research staff in studies that examine the role of nutrition in promoting health and preventing and treating diabetes and its complications. Join me in welcoming Rhonda Bell.
Okay. Oh, thank you very much for that introduction. And I just have to get out of this first. And then somewhere here must be my presentation. And I pushed this, I think. Oh, okay, there we go. Phew. First step done. And before I get started, I'd really like to thank Brendan and Kelsey for doing such an amazing job at introducing a lot of the work that I'm going to talk about today. So thank you for that background. And thank you very much to for inviting me as well. So today I'm going to talk about a project that we've had going on now for almost 5 years. It's called Enrich, and the goal of Enrich is in promoting healthy body weights in pregnancy among diverse groups of women. And I have no disclosures to make, except I have received some funding from the Alberta Pulse Growers to look at the health effects of regular consumption of dried beans and peas. So it's not really an important point for today's work, though. So by the end of this lecture, I'm hoping that based on the work I'm going to present, you'll be able to identify some of the areas that we've talked about that need attention from healthcare providers and women in order to promote healthy weights in pregnancy, and also develop an appreciation for the importance of bringing different types of information together as a way to clarify how we might go about promoting healthy weights in pregnancy. Finally, I'm going to talk about the two different areas that we've worked on. One is in universal strategies, and the second is selected strategies, and why both are needed to promote healthy weights among diverse groups of women. So by way of background, I'm going to show here what the current weight gain recommendations are that were first introduced in 2009 from the Institute of Medicine and later taken up by Health Canada. And these weight gain guidelines came on the heels of a couple of decades where women had been originally recommended to gain a minimum amount of weight. But in the decades that came following those recommendations, what people realized was that while women were now aiming to gain a minimum amount of weight, there was no ceiling on the maximum amount of weight that they may gain during pregnancy. So in 2009, the things that the IOM and Health Canada did were to identify that, first of all, pre-pregnancy weight was the basis for the amount of weight that women would be recommended to gain in pregnancy. They also noted that pregnancy-related weight gain should start primarily in the second and continue into the third trimester, and that women with different starting BMIs would then be recommended to gain different amounts of weight. So you can see here that women who are starting with a BMI in the underweight category would gain slightly more, and women starting with an overweight or obese BMI prior to pregnancy would be recommended to gain slightly less weight in pregnancy than those starting in the normal weight category. And finally, they also had a recommendation for the rate of weight gain, and basically it's giving guidance as to what you would expect the rate of weight gain to be, again, important for tracking throughout pregnancy. And the consequences of gestational weight gain have already been mentioned, actually. So for the pregnant mother, it's known that excessive gestational weight gain is related to is associated to an increased development of gestational diabetes and hypertensive disorders in pregnancy. At birth, it's also associated with higher rates of unplanned cesarean section, and both preterm and large for gestational weight age babies at the time of birth. And then as time goes on, it's associated with postpartum weight retention, which Brendan spoke about already this morning, and the ultimate development of maternal obesity, and it's also associated with higher rates of childhood overweight and obesity. So at the time that the IOM was releasing their guidelines, we also had a pregnancy cohort starting in Alberta, and in that pregnancy cohort, it's a prospective longitudinal cohort of women and their children, but we were fortunate enough to be gathering information about their weights all through pregnancy and actually into the postpartum period. So what we see here is the guideline concordant gestational weight gain of women it's called the APRN study, Alberta Pregnancy Outcomes and Nutrition Study, and if you focus first off on this normal weight group, so the proportion in blue are those women who gained below recommendations. The portion in green are those women that met recommendations, and the portion in red are those who gained above recommendations. So starting pregnancy with a normal body weight or a normal BMI was associated with about 22% of women gaining below recommendations and about 40% of women gaining above recommendations. And if you look to your right, you can see that the rates of excessive gestational weight gain are much higher, both in the overweight and obese categories. And these data are so reproducible, it's actually shocking. The numbers are almost identical from pretty much all developed countries around the world that have reported on these kinds of numbers. So with this as the backdrop, then, we had the chance to apply for a grant that would look at how we might improve maternal health in pregnancy and postpartum by promoting optimal dietary intake and weight management strategies. And the title of this program is called Enrich. We say it was birthed in 2013. Felt like it was a hard grant proposal to write, so it was it's kind of a fitting topic. And what we proposed to do there was to identify and evaluate innovative, universal, and selected strategies that might help meet the needs of diverse groups of women across Alberta. And I've got a picture of Dr. David Barker down there in the right-hand corner to remind me to mention that our work is all embedded in the DOHAD, or the Developmental Origins of Health and Adult Disease paradigm, again with the idea that by improving women's health prior to, during, and after pregnancy, we can have long-term impacts on their health and on their offspring's health. So many of the studies that have looked at intervening for promoting healthy weights in pregnancy have focused on the individual. And in this diagram, this is an ecological model that we've actually used to drive our Enrich program. And so here in the center, not sure if the mouse works here. Not really, okay. So in the center of the circle, we see women, and women make their own choices as they go through potentially one or more rounds of pregnancy and postpartum cycles. And there are individual factors that influence their dietary choices, physical activity choices, and many other aspects of their personal health behaviors. But we know that women are situated within different layers of influence, and that's where the strength of the ecological model comes from. So we know, for example, that women, of course, are bedded into environments that include their family members, their sociocultural environment, as well as potentially where their income sits. And we know that those more proximal factors are also embedded within larger spheres of influence that include community factors, geographic factors, healthcare delivery factors, and societal characteristics. And so when we're thinking about interventions, where most people have intervened primarily at the individual level, what we were interested in is looking to see how we might affect women's health and weight gain by changing some of the aspects of the different levels, those more distal levels. The areas that we focused on, the universal strategies, first of all, are those strategies that would be available and appropriate for promoting to the whole population, while selected strategies are those that would be available and optimize pregnancy and pregnancy outcomes for women who are particularly vulnerable. So we heard already from Kelsey about potentially being exposed to an unusual environmental stress like flooding or fires or so forth, ice storms. But there are others. So for example, women who are living in low income. We have immigrant and refugee women here in Canada, women who are geographically isolated because they're living in rural areas of our country, and Indigenous or Aboriginal women. These are just examples of groups that we have been interested in. So Enrich, I don't intend you to understand or to kind of get the whole project down, but we've used an integrated knowledge translation approach. And what we've done is we've organized our studies according to our partners. So we've integrated partners into our work right off the bat. And if you look, we have different, we call them POs, or program objectives, and we have partnered primarily with Alberta Health Services, and then a number of community-based organizations and an Aboriginal community, again, to understand how these different levels could affect pregnancy outcomes. The square around all of them is meant to show that we have crosstalk that goes between all of what looks like our silos, so we have a lot of crosstalk between them. I'm going to focus today on our work primarily with Alberta Health Services, and then also our work with a couple of our community-based organizations in our Aboriginal community, just to a small degree. And I wanted to remind myself to say that a lot of our work has been informed by our continued analysis of the APRIN cohort data, again, integrating information from a wide number of sources. So the first thing I'm going to talk about are our universal strategies. So these, again, are meant to be appropriate for all healthcare providers to communicate with all women. At the time that the IOM released the gestational weight gain guidelines, they also released what they, I'll say kind of euphemistically, called recommendations for universal implementation, because really it was just a list. It was a list of things that they felt healthcare providers and women should do without much guidance around how one actually does this. So the list includes recording pre-pregnancy height, weight, and BMI, informing women of the guidelines early in pregnancy, charting women's weight throughout pregnancy, sharing those results so that women are aware of their progress, and then offering nutrition and physical activity counseling. And on the one hand, 5 simple steps, seems like it should be a no-brainer. I'm sure it's easy to do in busy practices by people who may or may not have interest training, and so forth, related to these issues. So the very first thing we did was we tried to get a handle on what healthcare providers and what women thought about these issues, so that we could then, if we're thinking about interventions, we could then be informed by where the baseline was. So what we did for this was we conducted a national survey of healthcare providers. We also conducted healthcare provider interviews in Alberta and BC, and we did a literature scan to see about best practices and current practices. So that was primarily what we asked the healthcare providers. We also did a survey of Alberta women, and we conducted focus groups with women, again, to see what their impressions were already of their interactions related to weight gain and during pregnancy, but also to understand what they would like to have, because we felt like building an intervention that didn't consider both sides of that coin just ultimately wouldn't fly. So in our study of healthcare providers, again, we conducted a national survey. We ended up with about 600 healthcare providers, primarily physicians, GPs, OBGYNs, and different categories of nurses. And we asked them to tell us how often they have the following behavior in their practice. And the results that I'm going to show you are the proportions of healthcare providers who said that they did certain behaviors with at least 90% of their pregnant patients. So the question was, how often, for how many of your patients do you weigh them at every visit? And 76% said that they weighed at least 90% of their pregnant patients at every visit. How often did they relay weight gain information to women every time they weighed them? About 50% said they did that. How often did they provide pregnant women with a weight gain target based on their pre-pregnancy BMI? 21%. How often did they recommend rates of weight gain based on their target weight gain? 16%. How often did they discuss the impact of inappropriate weight gain with the mother? About 20%. How often did they discuss the impact of inappropriate weight gain on the baby? 19%. How often did they discuss physical activity with pregnant women? About 46% said that they did that with 90% of their patients. How often did they discuss appropriate food requirements with pregnant women? 28%. And 32% said that they could easily give appropriate examples of changes that women might make during pregnancy for their food intake. And 67% said they discussed prenatal vitamins. So I think this gives us an overall impression that's been reported by many others in the literature, that weight is measured regularly, but the follow-up and so forth, there are some gaps to fill. And so I think in our study here adds to the literature in that it's a nationwide survey and it surveys a number of different healthcare providers. The practices of the healthcare providers, as I mentioned, we did some qualitative work as well. And I think this quote is very timely, or is very telling. It says, I do not find that nutrition is covered in my medical school, and so therefore I don't have the background. Patients are asking about it, but I don't have a really good answer other than multivitamins. The next thing we did was we looked at gestational weight gain trajectories of the women. And the point that I want to make with this slide, so at the top we've got normal weight, middle is overweight, and the bottom is women who are obese in pregnancy. And what I've drawn, each of the trajectories has a time at which 75% of the group exceeded the gestational weight gain guidelines for that gestational age. So what you can see is that for normal weight women, it's exceeded at 33 weeks of gestation. For overweight women, 22 weeks of gestation, and for obese women, 18 weeks of gestation. So again, that's really informative in terms of helping people figure out what is early gestation. And we've looked at foods, dietary intake as well among our women, and this is a very busy slide, but the thing that I want you to take home is the title of this slide, which is that when we look at each of the different food groups in Canada's Food Guide, between 10 and 60% of pregnant women consume less than 1 serving per day of many of these important food groups. So this tells us that we need a toolkit then, one for healthcare providers, another for women, and we're just starting to roll these things out now. Our healthcare providers have asked us for posters, in-office tools, as well as continuing medical education, online modules, in order to increase knowledge and help them build skills, fostering appropriate women-centered counseling related to weight gain. For the women, we have a social media campaign, again, highlighting the importance of increasing their awareness. We've got print and hard copy resources and so forth for helping them track their weight gain. We've decided to use a set of communication tools called Healthy Conversation Skills, and we've piloted this approach. And basically, Healthy Conversation Skills relies on the how and asking how and what questions when working through, we've done it working through the first prenatal visit form. And so it helps women identify and healthcare providers identify where women may want to make changes, and ultimately, in some cases, they move on to a smarter goal. And this is just some examples of our gestational weight gain resources. I want to take just the last 2 minutes to talk about some of the selected strategies that we've worked on. And again, these are novel approaches to supporting vulnerable women. And what we've learned from the women that we've talked to in these different situations is that they have a very clear picture of what they should do in pregnancy. But then they like to say, and then life happens. So their experience ultimately is what they can manage in the midst of all the other things that are going on in their life, including things like family context, finance issues, health issues, childcare, etc. But what they've also noted is that community-based organizations are one of the key things that help them and support them through their pregnancy. We've worked with migrant women, immigrant and refugee, recent immigrant and refugee women, and they talk about what happened in their home country so that even though they were potentially experiencing strife and anxiety and so forth in their home country, they had a social network that supported them and that provided them with a lot of the either financial, social, and lots of other types of support. And that when they come to Canada, what helps here is the perinatal programs through the community-based organization. So we've worked primarily in this group with the Multicultural Health Brokers, a group in Edmonton. And the supports that they get here through the Multicultural Health Brokers helps to bring the support to what they had back home. And the novel part of this was we asked then the Multicultural Health Brokers, well then how can we help you provide more support for the women? And what they said is these women live in they call it a stew of crises. And the stew is what overshadows their ability to provide services to the women. And so, again, we've worked to develop food-based strategies, in particular a grocery run strategy that delivers food to the Multicultural Health Brokers, which they can then use to give to women in crises, so that when the women come and they need to have access to the holistic group of services, they've got the crisis dealt with, and then they're able to help on women move from the other areas of poverty. I'll just quickly talk about the Aboriginal community that we've worked with, which is just a little south of Edmonton. It's called Masquachis, and the community there felt that the most important thing that they wanted to do, and this is in partnership with their local primary care network, was to provide culturally safe prenatal care to their women. And so, again, with partnership between the community of Maskwacis and the Wetaskiwin PCN, they've established an elders mentoring program where elders from the community are now part of the standard health care in the PCN. So the elders, we have these signs, the elders are in, and the elders are able to meet with women who'd like to meet and talk to them about the cultural background and so forth of their pregnancy. So I hope through this talk you've gained an appreciation for understanding that promoting appropriate weights in pregnancy is complicated. Effective strategies that we're looking at will hopefully increase women's awareness and improve healthcare providers' knowledge and skills, but effective selected strategies are also needed, and community-based organizations play a large role in women's lives that they need, and they need support too. And I think I'm out of time. I know I'm out of time, so we won't have questions, but I'm happy to stick around afterwards. Thank you.
Thank you very much, Dr. Bell. Our next speaker is Dr. Jean-Patrice Balajan. I've been out of Montreal for about 30 years, forgive me. Dr. Balajan is board certified in endocrinology and metabolism and professor of medicine at the Université de Sherbrooke. Dr. Balajan primary interests are expertise include reproductive endocrinology, polycystic ovary syndrome, obesity, health system improvement, and biostatistics and epidemiology.
All right. So just let me put that on. So thank you very much for this introduction. Oh, it's not, I'll try to, okay. And I also thank the organizing committee for inviting me to present on this, I think, very interesting topic. So I don't, regarding disclosures, I only have one disclosure is that I'm evaluating candidates for clinical trials with many different pharmaceutical companies, that the companies are listed there. It's absolutely unrelated to the talk of today, so just mention it. All right, so first I would like to discuss the fact that obesity is bad for your fertility. So start with that. You are well aware that obesity is a growing problem in Canada. So it's also true for the younger population of women. So women in their reproductive age, 25% of them are overweight and 19% of them are obese. So that means that women are more likely to enter pregnancy overweight or obese nowadays. For example, in the United States, one study on 75,000 delivering women showed that 20% of them were obese pre-pregnancy. So obesity is a problem in that population that, at that age. On the other end, infertility is also a growing problem, is a problem that is important. So infertility is defined as the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse, and it affects 10 to 15% of couples, so it's not infrequent. There is many causes of infertility that are listed here, including hormonal problems, tubal blockage problems, smoking, stress, affects also infertility, endometriosis, age, etc. But the population and the community is not well aware that obesity is also a cause of infertility. Obesity can cause infertility through the development of polycystic ovary syndrome, which is very frequent and is, in fact, probably the most frequent cause of female infertility. But we also know that obesity can cause infertility directly. In fact, I would like to quote this study looking at the impact of obesity on women's fertility beyond PCOS, so beyond the fact that these women might have an ovulation. So they looked at ovulatory women who had at least one pattern tube. It was a cohort of more than 3,000 subfertile fertile couples, and they found that fertility decreased with increase in BMI. So for every BMI point between 30 and 35, there was a 5% drop in conception rates in these really non-PCOS ovulatory women. So as you can see, with a BMI of 35, fertility was decreased by 26%, and with a BMI of 40, it was decreased by 43%. So this is significant. And this, I would like also to quote another study, the Danish National Birth Cohort, who studied more than 47,000 pregnant couples with reported BMI and time to pregnancy in the database. So they looked at the adjusted odds ratios for a time to pregnancy above 12 months, which is the definition of infertility. And they find that women who were overweight or obese had increased risk for delayed pregnancy. So if the odds ratios were increased by 27% if the woman was overweight, and by 78% if she was obese. This is also true for men, although the number is a bit smaller, but men who are obese have an increased odds ratio by 49%. And in fact, if you have a combination of an obese woman and man in the couple, so both members of the couples are obese, the risk, the odds ratio is increased by 174%, which is more than the addition of the risk for each of the members of the couple. So obesity is important with regard to infertility for both partners. And as you already know, and it has been mentioned before, the impacts of obesity is also important on pregnancy outcomes and on the offspring. So we know that obesity increases the risk of adverse pregnancy and fetal outcomes, such as thromboembolism, preeclampsia, gestational diabetes, gestational hypertension, even death in utero, neural tube defects, prematurity, etc. And as it was mentioned before, there is also the Barker hypothesis, and we know that obesity causes epigenetic programming of the fetus, which is the implications that the offspring from obese women are at increased risk of developing later on obesity, diabetes, and cardiovascular disease, even early in age than the normal kids, the normal population. And this is not only true with excess gestational weight gain, but also based on the pre-pregnancy weight, and pre-pregnancy obesity also increase those risks. So this is also important because, as you can see, epigenetic may also contribute to perpetuate this vicious circle of obesity, because the mother is obese, can increase the risk of obesity in her children, including her daughter, who will introduce gestation as an obese or overweight woman, and then the vicious circle is perpetuated this way. So hopefully we will be able to break or cut this vicious circle. But exactly what can we do about it? So we know that obesity is bad for your fertility. What can we do? Lifestyle intervention is certainly something that we can do, but I'll try to show you some of the evidence that maybe lifestyle intervention in women with obesity and infertility might be helpful. So what would be the goal of lifestyle intervention? The general goal, in fact, will be to restore fertility while decreasing pregnancy risks for the mother and also for the offspring. What is the optimal weight loss that we should aim for? So the studies suggest that for fertility, 5 to 10% of initial weight loss would be enough. That doesn't seem very important weight loss, but we know that a weight loss of 5% is associated with a reduction of 30% of your visceral fat, and therefore would have important metabolic implications, benefits. Regarding lifestyle modifications per se, without weight loss, with or without weight loss, this might be also important to improve fertility and pregnancy outcomes, but unfortunately it has been poorly studied, and we hope to improve this gap, knowledge gap. Most of the studies looking at lifestyle modification for the improvement of fertility have been done in women with polycystic ovary syndrome. And in summary, these studies show that weight loss with or without exercise is effective to improve ovulation rates and even resume normal ovulatory cycles to improve fertility. Usually weight loss of only 5 to 10% is enough, as mentioned, such as it is recommended as the first-line intervention for all women with PCOS, in fact, not only those seeking fertility, but including women seeking fertility. But what about lifestyle intervention in women with obesity and infertility in general, outside PCOS? There is few studies, in fact. There is 2 studies that I will quote. The first study was evaluating the fertility fitness program in Australia. And this program enrolled women with obesity and anovulatory infertility. So it was limited to those women without ovulation and also non-smokers. It's a low-cost, minimal intervention. And the women who enter the program has to postpone their fertility treatment for at least 6 months. The program includes 2-hour weekly session. It's group session offering lifestyle education and supervised exercise training with an interdisciplinary team. So they did a randomized control trial to evaluate their program. They randomized 171 women to the intervention or the control group. As mentioned, for the first 6 months, the control group could start fertility treatment, but not the intervention group. And after 6 months, if there was no pregnancy, then the intervention group could start assisted reproduction treatments, and they were evaluated 12 months after an additional 12 months, so that would be 18 months of follow-up. And they've shown in that study that weight loss was more important in the intervention group, although the difference is not that big. As you can see, only 3.4 kilograms the difference between the groups. But in that study, pregnancies at 18 months were very much increased in the intervention group, 61% as compared to 21%. And both the pregnancy following RT, so advanced reproductive technology treatments, as well as spontaneous pregnancies were increased. So as you can see, there was twice as much spontaneous pregnancy in that study, and this was significant. And more recently, in fact, last year, in 2016, a large Netherlands lifestyle program study was published. So it was a randomized controlled trial published in the New England in 2016, as mentioned, who enrolled women with infertility and BMI of 29 or more. The randomization, again, was between the intervention for 6 months, preceding a treatment of infertility, or the control group could start promptly treatment for infertility. The intervention was more important, so it was monthly visit plus 4 phone calls with coaches. The coaches were nurse or nutritionists. They were advised on nutritional and exercise, and they also received motivational counseling with individualized goals for the participants. And the primary outcome was vaginal birth of an healthy singleton at 24 months after the randomization. They had 22% of the participants who discontinued the lifestyle intervention, which is not surprising, that kind of intervention. And in those who completed the 6 months of the intervention of 6 months, there was 43% who lost at least 5% of their initial weight in the intervention group with the lifestyle intervention, as compared to 0% in the control group. The control group was left to usual care. So they found in that study that natural conception, spontaneous pregnancy, were significantly increased in the intervention group. It was so the 26% of pregnancy as compared to 16%. Not as large as the previous study, but it was significant. And the intervention group used less treatment during the study. However, the primary outcome was not improved in that study. There was no difference between the group, even a trend with less live birth in the intervention group. Nevertheless, actually, the recommendation is really to is to manage overweight and obesity in women, so make sure that they receive counseling and strategy to obtain or remain at an healthful weight. So this is a recommendation from the American Diabetes Association, from the American Society of Nutrition. The American Society for Reproductive Medicine also recommend that lifestyle change are implemented, as well as the British Fertility Society. And the European Society for Human Reproduction also recommend lifestyle intervention in obese or overweight women before pregnancy, before conception, and they also recommend that more studies should be done. So we know that obesity is bad for fertility. We know also that lifestyle modification could maybe improve those outcomes, but what do we do now in Sherbrooke? So we received a grant to evaluate for studies. The name of the grant, the title was to the evaluation of clinical outcomes and costs of a transferable interdisciplinary lifestyle intervention in obese infertile women. And we received funds from CIHR and other partners. The objective of the study is to evaluate lifestyle benefits of a program and our program and assess its impact on fertility, pregnancy, and neonatal outcomes, and also to assess cost per live birth and other indicators of cost effectiveness. The research design is a randomized controlled trial in Sherbrooke, assessing this in our interdisciplinary lifestyle intervention. And we will compare our results with other clinics in Montreal, Toronto, and Edmonton. The research is ongoing, actually. It's not completed, but I will show you some preliminary results. Our selection criteria, so the inclusion criteria are very large. We take women between 8 and 40 years old who are obese or overweight if they have polycystic ovary syndrome, and they have to have infertility. So it's very broad inclusion criteria. We have only 2 exclusion criteria, is when IVF is the only option, and if bariatric surgery was performed in the candidates, or if she were planning for it. So that would be an exclusion criteria. So far we have randomized 130 women. In fact, the randomization, the recruitment is completed. We had to exclude 3 women and 2% of the cohort, and 20% of the participants withdrew the study so far. So per protocol analysis will be on 101 women so far, although the study is not finished. And they are randomized to the standard fertility treatments or our lifestyle program, the Ferti Santé program in Sherbrooke. And again, for the first 6 months, they have to postpone fertility treatments, and they can start fertility treatments after 6 months. A big difference of our study as compared to the previous studies were that we continue the intervention after 6 months, and we also continue the intervention during pregnancy. So we have results on 77 women so far, and I will have to go a little bit faster. So the program is the Ferti Santé. We have individual meetings every 6 weeks with the dietitian and the kinesiologist, and we have group sessions every week. We have 12 different weekly group sessions. We have evaluation every 6 months and during pregnancy as well. Rapidly, our results so far, 77 women. Baseline characteristics are similar between groups. and weight loss is not very important. Our approach is, I didn't mention it, but with also motivational interviewing. It's based on the Canadian guidelines, so it's not an intensive lifestyle modification approach. But we have improved significantly nutritional status, and also sedentary activities were significantly improved by the program. And pregnancy rates were increased so far from 41 to 69% pregnancy in the intervention group. And most of the pregnancy were spontaneous in the intervention group as compared, and that was significantly different from the control group. And live birth so far is improved by the intervention. So we have 16% absolute difference rate in the live births between the two groups. And I will skip that. So our conclusion from the primary results is that our lifestyle intervention in obese infertile women, even with a modest weight loss, could improve pregnancy rate, mainly the occurrence of a spontaneous pregnancy, and there is a trend for improvement of rate of live births. And so such intervention may improve fertility also by other means than weight loss, because our lifestyle modification were more important than weight loss in our study. Oops. And in summary, obesity management through lifestyle modification and other modalities is feasible and effective in obese and fertile women. Women seeking fertility treatment are highly receptive to lifestyle modification, we think, and interdisciplinary interventions are usually privileged. And weight loss and or lifestyle modification can result in improved fertility, at least that's what we find in our hands, and better pregnancy outcomes, hopefully. We'll see. The results of the final study will be published maybe in 1 year or 1.5 years. So thank you very much. This is the group that participated in that study and other studies related. Thank you for your time, and I'll be happy to have questions after. So thanks.
Wonderful. Well, thanks everyone for your time and attention today. A huge thank you to our 4 fantastic speakers. I think we all had a lot to learn and lots of interesting research initiatives going on to understand this complex area as well. It's 9:30, so I'm going to bring this to a close. Thank you, Dr. Binks, as well, for co-chairing with me. I believe there is a nutrition break, so maybe we'll just end with a round of applause, and I think our speakers are maybe willing to stick around for a few minutes for questions. So thanks, everyone.